We're talking on adrenaline versus tranexamic acid for intraoperative hemostasis in PDR, a randomized control trial. So no financial interest in this presentation. So, or the products used. So intraoperative bleeding in diabetic vitrectomy is one of the major concerns, especially for a surgeon who's sitting and operating 1, 2, 3 hours. So it obscures the visualization and also prolongs the surgical time. So what are the techniques for bleed management which has been used previously? Pre-op anti-VEGF has been used intraoperatively. You raise the intraocular pressure. You can do multiple, intraop diathermies. Also, you can use heavy liquids like PFCl to tamponade or, reduce the bleed which happens. So let's talk about some pharmacological adjuvants which have come recently into the limelight. So one of them is tranexamic acid and the other one is adrenaline, which was also used previously. So what is the mechanism of tranexamic acid? It's an antifibrinolytic. It basically stabilizes the clot and prevents the action of plasminogen conversion to plasmin and then formation of fibrin. And whereas the adrenaline, through its alpha-1 receptor, it acts on the alpha-1 receptor and causes vasoconstriction and thereby reducing the flow and thereby reducing the intraocular bleed. So the aim in this study was to directly compare both these pharmacological adjuvants added to the infusion bottle in achieving intraoperative hemostasis, that is tranexamic acid versus adrenaline. And so this was the methodology of a prospective randomized control trial, 40 eyes of 40 patients, 20 in each group, 1:1 randomization. And eligible patients with PDR were taken and data analysis was done with SSPS. So these were the inclusion-exclusion criteria. Adults more than 18 with diabetes, active PDR, non-clearing vitreous hemorrhage, waiting after 1 month non-clearing, even a few fractional detachments were taken. Exclusion were recent anti-VEGF. So anti-VEGF was excluded from this study. That means now the trend is give anti-VEGF 5 days or 1 week pre-op and then take the case. So anti-VEGF was excluded, not given. Previous VR surgery excluded, one-night status excluded, any cardiac CKD and those on anticoagulant were also excluded from this study. So it was randomized 1:1. So we prepared tranexamic acid 100 milligram per ml, so at least 4 vials. So 1 gram, 500 milligram in 5 ml, so at least 4 vials of those. So 1 gram was used in 500 ml of BSS, and adrenaline was only 1 milligram per ml. It mixed in 500 ml of BSS. So this masking was also done. The surgeon also did not know what was used, and also there was a primary evaluator who was observing each case, so they were also masked towards this. So what were the outcome measures? So intraoperative bleeding score was there, 0 to 3, no intraoperative bleeding 0, 3 severe bleeding requiring prolonged maneuvers, and also visibility score 1 to 3, poor visibility and also good visibility. So primary outcomes were the intraoperative scores and the number of diathermy applications. Secondary outcomes were the visual acuity and the intraoperative visibility score, mean operative time, etc. So these were the baseline demographic data. Both groups were age matched. The sex, male, female was also age matched. Equal number of hypertensives and those with the previous PRP was also matched, and preoperative BCVA is also similar in both the groups. So these were the outcome measures. So bleeding score. So adrenaline group had less amount of bleeding as compared to tranexamic acid, 1.3 plus minus 0.5 as compared to 2. According to the bleeding score, what I showed previously, this was quite significant, and even the endothermy applications were lesser in the adrenaline group as compared to the tranexamic acid group. Whereas the operative time and the visibility score were almost similar in both the groups. The second outcome measure, early post-operative vitreous hemorrhage, 1 was there in the adrenaline group and 2 were in the tranexamic acid group. Again, it was not significant. The sample was too small to provide a significance, and also visual acuity at 1 month was similar in both the groups, and no other intraop complications or post-op complications were seen. Even systemic complications were not seen. So there are few limitations of this study. Small sample size. It's a single center study. There was no control group. We should also have had a control group of normals. We did not have that. And if you look at the literature review, this is the first study to analyze the intraoperative use of these two adjuvants, against each other. So no literature is there on intraoperative use for this particular vitreous hemorrhage in PDR patients. Most of them, the literature examines only the post-vitreous cavity hemorrhages after use of these adjuvants. So to conclude, adrenaline, when compared to tranexamic acid, has a superior hemostasis, reduced bleeding scores, and fewer number of diathermy applications as compared to tranexamic acid. Yeah, thank you. So this is the case where you can see adrenaline has been used, and when you're removing these FPs, even those point bleeders are blanched because of the use of adrenaline.
Thank you, Shishir. How many times did you have to raise the IOP in these two groups? Is there any comparison? And
Yeah,
how much time you had to keep it raised?
Yeah, IOP was raise lesser in the adrenaline group as compared to the tranexamic, because
but
the
it doesn't come
tranexamic
in your,
acid still oozes.
yeah, but it doesn't come in your comparison.
Yeah, that I didn't.
Actually, this was used year as early as 1987. But in 2021 in Retnet, there is a paper, similar paper.
Yes, abstract is there.
Yeah, abstract is there, and in fact, they have used intraoperatively.
Yes.
And second thing is, in that case, they have given preoperative ILIA in all cases in both the groups.
Yes.
So, have you given anything, number one?
No, no anti-VEGF. Then we don't know what is working.
Okay. So, number two, actually, when they are giving systemically, they have come across CRVO and all, because it tends to clot.
Clot, yes.
So, when we are, exposing the vitreous cavity for such a long time, is there any risk of going in for CRAO or CRVO in these cases?
So there's
Theoretically.
one case report of CRO formation has been reported with the use of adrenaline. Not intraoperative for diabetic, but for the when you add in the infusion to dilate the pupil in cataract surgery, it has been reported.
Thank you. Can we call upon the next speaker, Dr. Minnie David? If someone else is presenting on your behalf, please let us know.
Good evening. I'll be talking on proportion of vision-threatening diabetic retinopathy on initial diabetic retinopathy screening in a tertiary eye care hospital, Kerala. Diabetic retinopathy at the earliest stages is largely asymptomatic. Patients need to undergo regular screening to detect treatable retinopathy before vision is affected. Vision-threatening diabetic retinopathy includes advanced stages of diabetic retinopathy. In recent population-based multi-center study in India, the national prevalence of DR and VTDR were 12.5% and 4% respectively. In this study, we propose to identify the proportion of diabetic patients who present with VTDR on their initial diabetic retinopathy screening. VTDR includes severe non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and diabetic macular edema. Aim of the study is to determine the proportion of vision-threatening diabetic retinopathy among diabetic patients on initial DR screening. This was a hospital-based retrospective observational study. Data of 533 people with type 2 diabetes mellitus getting screened for the first time for DR at Retina Clinic of a tertiary eye care hospital, Kerala. Data was collected over 7 months in 2024 from January to July. All diabetic patients more than 18 years attending regular outpatient department undergoing their first DR screening were included in the study. Patients with significant media opacities, other retinal pathologies such as age-related macular degeneration, vascular occlusion, vitreomacular interface diseases excluded from the study. Also, diabetic patients on regular follow-up and prior treatment for DR were excluded. Data collection included basic demographics and ocular parameters. Fundus examination was done using slit lamp biomicroscopy with 78D lens and direct ophthalmoscopy with 20D lens. Grading of DR was performed using International Clinical Diabetic Retinopathy Severity Scale, and fundus photo and OCT were performed in necessary patients. Chi-square test and independent t-tests were the statistical tests used to compare the gender and age differences within the VTDR group, and p-value of less than 0.05 was considered statistically significant. Coming to the results, 76 out of 533 diabetic patients were presented with VTDR. 14.3% were found to be VTDR. Mean age of presentation was 61.7 plus or minus 9.3 years. 56% were females and 44% were males. Almost 60% of patients were found with no diabetic retinopathy and 40% presented with the diabetic retinopathy. 4.7% presented with severe NPDR, 6.6% presented with PDR, and 3% presented with center involving DME. PDR patients were the highest percentage of group among VTDR patients. VTDR trends in gender category, males had a higher proportion of VTDR compared to females. Age group in VTDR patients are significantly younger on an average than those without VTDR. Coming to discussion, VTDR seen at presentation were 14.3% of type 2 diabetes patients undergoing their first DR screening, higher prevalence among younger individuals and males. 50% of patients did not have any DR and 28% presented with early DR. Proportion of VTDR higher than the national prevalence-based estimates, which reported a 4% prevalence of VTDR among people with diabetes more than age 40 years. This high proportion in our series is consistent with trends observed in other hospital-based studies, which typically report greater VTDR prevalence due to opportunistic screening, referral bias, and inclusion of symptomatic patients. Speed study conducted across multiple tertiary eye care centers reported a DR and VTDR prevalence of 32.3% and 19.1% respectively. Our findings of VTDR were higher than that reported from previous hospital-based studies in Alaska, that is 4.2%. An Ethiopian hospital-based study found 13.7% VTDR with male gender, poor glycemic control and hypertension, and longer duration of diabetes as identified as significant risk factors. Another study by Glover et al. Found that 19.7% cases of VTDR in patients attending a hospital in sub-Saharan Africa. Another study by Subkota et al. Found 80% of patients attending a specialist eye clinic in China had VTDR with 67% prevalence among first-time attendees, male gender, longer diabetes duration being significantly associated. The relatively higher proportion of VTDR in our first-time screening cohort highlights the delay in presentation of DR screening. Delayed screening and lack of awareness positive symptoms in the early stages of DR contribute to burden of advanced disease at diagnosis. Early DR is asymptomatic, and vision loss due to VTDR can be largely prevented through systematic screening, timely laser and anti-VEGF treatment, and optimal control of modifiable risk factors such as hyperglycemia, hypertension, and nephropathy. Our recommendations from the studies integrate DR screening into routine diabetic care pathway, strengthen referral system, enhance patient education to prevent irreversible visual impairment during the most productive years, mandatory DR screening for younger onset DM patients. Strengths and limitations of the study. Strengths: exclusive inclusion of first-time screening attendees providing an accurate snapshot of disease burden at initial presentation, relatively large sample size, use of ICDR classification ensure the methodological robustness and allow comparability with other studies. Coming to limitations, risk factors such as longer duration of diabetes, poor glycemic control, presence of comorbidities were not included in the study. Retrospective design precluded the collection of complete data and reasons for delayed presentation, and regional settings in Kerala findings may not be generalizable to areas with different healthcare access and demographic profiles. We concluded that VTDR was found in 14.3% of type 2 diabetes patients undergoing the first DR screening with higher prevalence of younger patients and males. These findings underscore the urgent need for early and routine DR screening to prevent irreversible visual impairment. These are the references.
Actually, two important things are the duration of diabetes and the HbA1c. Both were not analyzed. We don't know what was the duration. Number two, I think yours is a tertiary eye care hospital. It's not a general hospital. So all these patients were screened in the retina clinic, or you have got a general ophthalmology also where it was screened. Because the patients coming to retina clinic will be having some issues, either referred or with morbidity. So naturally, the incidence of the prevalence of vision-threatening diabetic retinopathy will be more. So have you screened the patients who are coming to general ophthalmology also with the diabetes without any
Yes.
referral?
Yes, sir. All general cases were included.
Was it entirely the patients who walked into your hospital, or did you do a community screening along with that to identify
Not
this?
included the community screening, like a patient with first DR screening came to the hospital was included. All diabetic patients were included.
Okay, then one more question. You repeatedly said prevalence of vision-threatening diabetic retinopathy is more in males.
No.
Does that mean that out of 100 you picked up 60 were males and 40 were females? Or out of 100 males who turned up, did you have more males who had vision-threatening diabetic retinopathy compared to the proportion of the females?
It was
Did
a
you get my
prospective
question?
study, sir. So we didn't the patients like we got it data collection.
It's simply that out of the patients you picked up, this much patients, a percentage was
males and-
males and this
yeah.
much was females. Didn't do a subgroup analysis to see how many males out of those who turned up had VTDR and how many females out of those who turned up had VTDR. That was not done. Okay, why I'm asking this specifically, because there is a gender bias for males turning up to the hospital more than females. Next presentation will be by Dr. Jyoti Prakash Vyas.
Ksos for the opportunity. My topic is anatomical and functional outcomes of a modified internal limiting membrane peel technique in a macular hole surgery, a retrospective case series. Idiopathic full thickness macular holes are a major cause of central vision loss above the age of 55 and mainly in females, the incidence being around 3.3 per thousand. Standard treatment includes pars plana vitrectomy with internal limiting membrane, which achieves an anatomical success of about 85 to 95%. The poor prognostic factors usually are longer duration of the disease, larger macular holes, and a lower macular hole index, which tend to necessitate modifications in techniques for improved surgical outcomes. The different types of ILM flaps which have been utilized across decades have been the standard ILM flap. Then there can be one which is called hinged or a temporal flap. Then there is another which is called a retracting door flap and a superiorly hinged retracting door flap. They have been named according to the surgeon who have used it, and this is one which is known as the cabbage leaf flap. There are latest uproar about a few different techniques in which they have utilized peel, in which they have utilized the finesse loop and finally completed that with the cutter. So these are the few examples of videos which have been taken from the net. So with this idea in mind, we evaluated the anatomical and functional outcomes of modified ILM peel technique at our center, which was a retrospective studies interventional case series of 30 eyes from 28 consecutive patients, including 2 with bilateral disease, presenting between December 2024 and April 2025. The patients with idiopathic full thickness macular hole diagnosed on clinical examination as well as confirmed on SD-OCT with a complete pre-operative and post-operative documentation were included. A minimum 1 month follow-up with SD-OCT and subsequently at 3 and 6 months, and all the patients were above the age of 18 years. Patients who had undergone previous vitreoretinal surgeries had secondary macular holes due to trauma or other causes, and significant media opacities which precluded to visualization were excluded. Outcomes were analyzed on the basis of anatomical closure rates, visual outcome acuity changes, and morphometric analysis. The technique included the standard 23 or 25 gauge 3-port pars plana vitrectomy, included PVD induction, core vitrectomy, PVD induction, completion of vitrectomy, fluid air exchange at the end of the thing, and staining with brilliant blue, followed by the modified ILM peel, in which circumferential peel of around 2 to 3 disc diameters were done all around the macular hole, and the ILM was left deliberately at the edge of the macular hole without stuffing any tissue into the macular hole per se. Then the fluid air exchange was done, and a tamponade was given with 20% SF6, and a prone positioning for 3 to 7 days post-operatively was followed. Coming to the results, 65.3%, 65.3 years was the mean age in our series, and 78% were females. Majority of the patients had a duration of 6 months or less. The modified ILM technique which we observed in our series, we had an overall closure rate of around 96.9%, which was slightly better than the success rate which has been said according to the conventional reports. This was how the type 1 closure, type 2 closure, and a persistent macular hole looked like in our cases. These are few of our representative cases during the surgery. Left side, you can see the pre-operative picture. Right side, 1 month post-operative picture of the same patient who had undergone the surgery. And all of the patients, most of them had a baseline basal diameter of more than 1000 microns, as can be evident in the slides. These are 2 cases which landed up with a persistent one was a persistent macular hole because it was a cardiac patient who was unable to lie prone, and actually following the surgery, the macular hole base diameter increased in size, you can see to the right of the slide. And the bottom was a patient who who landed up with a type 2 closure because at baseline itself, the basal diameter was around 2000 microns. Coming to the functional outcomes, there was a modest visual improvement at 1 month follow-up, and these visual gains were maintained at 3 and 6 months, and none of them observed a drop in vision. 50% showed an improvement at 1 month, and which improved slightly to up to 71% at 3 months, and it was maintained at 6-month follow-up. The macular hole index analysis showed that the patient with a poor macular hole index, that's an MH index less than 0.5, the success rate was 91.7, which is better than 80%, which has been reported in literature. The surgical management of full thickness macular hole is often challenging. In our experience, modified ILM technique led to a complete closure and a significant visual improvement. The mechanism which is said to help in this ILM peel technique is glial migration as well as neurotropic factor released by the migrating Muller cells. And chronic holes and larger macular holes are probably the ones which are going to benefit more by this technique, as was evident by the anatomical success rate in 96.9% of our series, and in a poor macular hole index group, the success rate was a better 91%. This technique demonstrated excellent safety profile with no complications intra-op or post-operatively, and may be a viable choice for chronic macular holes and shows a promising, reliable technique for future.
You have a control group for this?
No, sir. This was only a retrospective series, and all of the cases underwent the same pattern of cases, surgical technique. I'm sorry.
No combined procedure, all are only macular hole. In the sense, with cataract, nothing was done.
Cataract was done. Cataract was done in.
How many cases? Like,
Pardon, sir?
now, out of 38 eyes, 40
Yes,
eyes,
yes, sir.
how many underwent cataract plus vitrectomy? And
15. 15 were out of which were underwent cataract surgery. It could be phaco or manual SICS. And in such the case, I am sorry, I think I missed out that slide. There was a 100% closure rate.
Thank you. Next, we call upon Dr. Vishak Kumar Kadakat for the presentation.
Good evening all. My paper is titled External Subretinal Fluid Drainage for Atypical CSCR with Extraretinal retinal detachment. Atypical CSCR is rare and the data on their specific incidence is limited. It is characterized by a bullous inferior retinal detachment, and this prolonged detachment can lead to irreversible photoreceptor damage. So our study design, it is a retrospective analysis of a case series between the period of 2017 and 2025 at a tertiary care referral hospital, and out of 31 eyes diagnosed as atypical CSCR, 5 were taken in for the study. So the inclusion criteria, all cases of diagnosed CSCR which was confirmed by multimodal imaging was included, and those eyes where conservative therapy or laser monotherapy was not viable were taken into the study. So these are the multimodal imaging modalities that was used. And as for the surgical procedure, after 360-degree conjunctival peritomy was done, the recti muscles were tagged and hooked and tagged, and a partial thickness clearal window was made. After which an AC maintainer was put in so that the globe does not become hypotenuse during drainage. And just before drainage, an indirect ophthalmoscopy is done so as to assess the area of maximum detachment, and drainage is done with a needle. As we can see here, there is subretinal fluid which is coming out from the site of drainage. Post-operatively, angiography was done on the post-op day 1, where any new or residual leaks were identified, and focal laser was done to them, and the patient was followed up with OCT at 1 week and 1 month post-operatively. So the outcome measures, the primary outcome that we looked into was complete restoration of the subretinal fluid and retinal reattachment. We also looked into the best corrected visual acuity changes, any complications or recurrence of the condition. The BCVA was compared pre and post operatively. So this is a table which shows the patient demographics. The mean age of presentation was about 48.8 years. In our study, 4 were males and 1 was female, and none of the patients had any history of systemic steroid use. This is a table which shows the clinical characteristics of the patients, the 5 eyes, in which eye 3 has been highlighted, in which the patient had an initial visual acuity of counting finger 1 meter, which had improved to 6/9. And these are the results. We found that all the patients had complete restoration of subretinal fluid and retinal reattachment, which was confirmed by OCT. There was visual stabilization, meaning that the initial best corrected visual acuity was similar to the post-operative one, and there was no recurrence of extraretinal detachment over the mean follow-up of 32 months. As for the complications, one patient had a retinal incarceration, which was treated with a segmental buckle, and one patient had mild vitreous hemorrhage, which was managed conservatively. So this is the I1 in which an inferior detachment can be seen, which can be seen in OCT as well as the B scan. An angiography was done in which a focal leak can be seen in the superior retina. We tried laser to it, but there was no resolution of fluid. Hence, we took up the patient for the surgical procedure. Post-operative day 1, an angiography was repeated, and we can see new areas of focal leak in the inferior retina, which was previously masked by the bullous detachment. And post-operatively, 1 month, the retina was attached, and the OCT showed no fluid. This is I2 in which similarly an inferior extremity detachment is there, which can be seen on B scan. And OCT showed subretinal fluid along with the fibrin-like material at the macula. Angiography showed a few areas of leak to which laser was tried, but there was no resolution. Hence, the patient was taken up for surgery, and post-operatively 1 month, the retina had attached and there was no fluid. This is the third case which I had highlighted earlier, in which the patient had an extremity detachment. OCT showed the presence of fluid, and angiography showed a RP rip in the supranasal quadrant, but there was no laserable areas. Hence, we took her up for surgery. And post-op day 1, and a focal leaking area was seen in the inferior retina, to which laser was applied. And down the lane, in post-op 1 month, the patient vision had significantly improved, and this is her post-op OCT. Similarly, I4, in which the inferior detachment can be seen. A few areas of focal leak was there, to which we did apply laser, but there was no resolution. And this patient was also taken up for surgery, and post-operatively 1 month the retina had attached and there was no fluid. This is the last eye in which this patient presented to us with a superior scotoma. He was actually advised for vitrectomy from elsewhere with the diagnosis of rheumatogenic retinal detachment. We did a multimodal imaging which showed us that the diagnosis is actually chronic CSCR, atypical CSCR. So this patient angiography did not show any laserable area, so we took him up for surgery, and following which few suspicious leaky areas were seen in the angiography, for which laser was applied, and 1 month post-op his retina was attached and his visual acuity had also improved better. So discussion, atypical CSCR is a diagnostic challenge owing to a similarity between rheumatogenic and inflammatory detachment. This is the case where this time when multimodal imaging comes into play, and we found that SRF drainage followed by angiography and focal leak was helpful. So this is a similar study which was done by Shailaja Bondapati et al. In 2015, which is similar to our study. So the key findings of our study is that surgical complications are there, but it is preventable and manageable with careful technique. There is visual stabilization for all the patients. There is complete resolution, and no recurrence of the condition was found. And why it matters is that it is an unexplored territory, that is atypical CSCR, for which external drainage is being done. It has not is been poorly documented, and it is stable. And this is one eye in which the patient was with atypical CSCR, in which the patient was managed conservatively, and he had a visual acuity of counting finger 1 meter. And this is our patient for whom we did SRF drainage followed by angio and focal, in which she improved to 6/9. These are my references. Thank you.
First point is like this exudative RDs, when the patient lies prone, there will be shifting of fluid.
Yes, sir.
So it's going to be collecting over the
posterior.
posterior pole. So the periphery will be flat now. So how to drain that, number one. Number two, why to bridle and go for cut down? Because nowadays, if at all you want to drain, we can drain with the non-val 23 or 25 or 27. So that will give a complete thing. My worry in this case is you have bridled all the 4 muscles.
So actually, we depending upon the quadrant in which there is maximum detachment, we tag those 2 muscles.
Okay,
Basically.
but 360-degree peritomy done in all cases.
Most of the cases, yes.
Yes, no, 45 case. The reason is how can you put the contact lens on POD1 in this size? Because it will be painful. Contact lens to do you have done as
Yes,
per
sir,
your
yes.
methodology, it says on POD1 you have done the lasers.
Yes.
So when we are putting contact lens in literally post-operative traumatized eye, it will be even more painful, number one. And number two, in 5 cases where you have shown post-ops,
Yes.
you said one case had retinal incarceration with buckling later on, but that picture was never seen.
So buckling was done, like we found retinal incrustation just after drainage. So
Yes.
we did buckling on the same time itself.
Yeah, but we could have seen at least the buckle height or the site of
So that
incarceration.
because I didn't have the peripheral photo of that patient.
Was
No, that laser, how it was done?
So laser was done post-op day 1 itself. We had put in Paracaine 2-3 times. Then the patient was able to manage it.
Patient will manage.
It's like they didn't complain. Also, they didn't have much pain. That is what we managed.
Don't say they didn't have pain.
Okay, what was your inclusion criteria? Was it just the chronicity and your diagnosis, or was there the height of the fluid which was
So there
included
was,
as inclusion criteria?
we didn't check the height of the fluid. What we looked into was that if it is a case of CSCR, can we do laser? So if laser was not possible, or even after laser there was no resolution of fluid, then we would take up the patient for the surgical procedure. Or if after an angiography there is no laserable leaks, then we would take up the patient. We didn't look into the height of the fluid, but definitely if the macula was involved, we would have done it earlier.
And how far posterior did you have to go and drain?
Sir, it was we went maybe just beyond the just close to the equator, near the equatorial area. That is it, sir.
Just like what Naresh sir was asking,
Yes, sir. We
didn't
did
the
found
fluid go posteriorly when the patient was lying down? So how
The-
did you
the-
manage drainage there?
the fluid did go posteriorly, but we did a careful IDO. We looked at the area which was maximum fluid accumulation was there, and then we did a scleral cut down, and then we did the drainage. Most of the fluid did come. So what we found is that the next day, post-operative day one itself, the rest of the fluid had gone. Even though some fluid was remaining, the next day it had rest.
And did you give any tamponade? No no air, no gas,
So
nothing.
it was just an external drainage procedure. We didn't go for then AC maintenance was put so that the globe doesn't go hypertrophic.
Thank you.
Thank you, sir.
Next we call upon Dr. Alphonse Babu.
Good evening, everyone. My topic is to evaluate the efficacy and safety of adalimumab in patients with non-infectious uveitis. TNF-alpha is a pro-inflammatory cytokine which activates cytokine-driven inflammatory processes, and high levels are seen in aqueous humor during active uveitis. Adalimumab is a humanized recombinant monoclonal anti-TNF antibody. It is well tolerated due to low immunogenicity and is effective in infliximab intolerant and refractory uveitis. Aim of my study is to study efficacy and response of adalimumab in achieving remission or inactivity in patients with non-infectious uveitis, and to evaluate side effects of adalimumab during the course of treatment. It is a retrospective observational study done from January 2015 to April 2025 using the electronic records of 37 eyes of 20 patients of non-infectious uveitis treated with adalimumab at Contrast Eye Hospital, Calicut. Coming to definitions, remission is no sign of inflammation for 3 months after cessation of systemic immunomodulating therapy. Inactive disease is no sign of inflammation for 3 months during treatment with systemic immunomodulating therapy, including systemic corticosteroids, and relapse is active inflammation after inactivity for at least 3 months. Successful tapering of systemic corticosteroids is taken as 10 mg of less of prednisolone per day according to some criteria. Primary outcome was effectiveness of adalimumab indicated by patients achieving inactive disease, remission, or relapse-free period. Secondary outcome was reason for discontinuation, including side effects. Inclusion criteria was non-infectious uveitis treated with adalimumab and follow-up of minimum 3 months, and exclusion criteria was inadequate documentation and follow-up less than 3 months. Statistical analysis was performed using SPSS 22.0, and results: analysis of 37 eyes of 20 patients from January 2015 to April 2025 was done. Relevant ocular and laboratory investigations were done wherever required. The mean follow-up period was 13 plus minus 9.50 months. Demographic characteristics: total patients were 20, including 11 females and 9 males, which was comparable. Pediatric cases were 60%, and the median age was 15 plus minus 15 years, and bilateral involvement was seen in 17 patients. Etiology included VKH, IRWAN, Behçet's disease, juvenile idiopathic arthritis, sarcoidosis, and idiopathic panuveitis. Efficacy measures: remission inactive disease was achieved in 14 patients, which amounted to 70%. Steroid-free status in 15 patients. Recurrence while on adalimumab was seen in 5 patients. Ongoing activity in 6 patients. The mean treatment period in patients who achieved remission or inactivity was 14.57 plus minus 9.69 months. Concurrent therapy of adalimumab was done, including methotrexate, mycophenolate mofetil, and steroids in various combinations. Visual acuity analysis showed improved visual acuity in 26 eyes amounting to 70.3%, and significant visual improvement was seen in 20 eyes.
Complications. Complications were majorly attributed to uncontrolled uveitis over time rather than to adalimumab itself. Ocular complications of posterior subcapsular cataract, band-shaped keratopathy, cystoid macular edema, and epiretinal membrane were seen. Surgical interventions for CME with PST and Ozurdex injections were given in 1 and 2 eyes, cataract surgery in 3 eyes, and combined surgery with cataract vitrectomy and Ozurdex injection in 1 eye was done. Anti-glaucoma medications were continued in 3 eyes. Treatment discontinuation in 1 patient was due to tuberculosis development, patient decision to discontinue in 3 patients, and loss to follow-up in 3 patients. No systemic side effects of adalimumab were reported except for TB in 1 eye, 1 patient. Primary efficacy endpoints of remission and inactivity were achieved in 70%, steroid sparing effect in 75%, and visual acuity improvement in 70.3%. Discussion. Adalimumab is well tolerated in majority of patients and was continued for as long as 3.5 years in our study. 60% of our patients were of pediatric age group. Visual acuity in our study had improved in 70.3% of eyes, and the loss of vision was attributed to uncontrolled uveitis over time. Remission and inactive disease achieved in our study was 70%, which was comparable by a study by Nida Khan et al., which was 79.3%. Visual 3 study showed sustained control of uveitis with adalimumab, and Sycamore study in JIA showed effective control of uveitis in 56% with adalimumab that did not respond to methotrexate alone. Now, TB risk with TNF alpha antagonists were studied by Zhang Z et al. With this meta-analysis of 29 RCTs, which showed increased risk with odds ratio of 1.94. In our study also, 1 patient had developed TB and adalimumab was stopped in that patient and ATT was started. Now, contracting TB's risk was higher when adalimumab was used in combination with other immunosuppressive agents versus monotherapy. 2 patients who had stopped adalimumab on their own developed recurrence and they were started on methotrexate. Laura M. Urelling showed that steroids and DMRDs in addition to adalimumab could prevent the formation of adalimumab antibodies, which can lead to reinstatement failure. Anti-TNF therapy that could worsen demyelinating diseases were reported. No such case was seen in our study. And affordability of adalimumab India is definitely a challenge. Limitations, small sample size, and further follow-up period to assess long-term effects of adalimumab is needed. Conclusion. Adalimumab is well tolerated, safe and effective in treatment of non-infectious uveitis with inadequate response to other immunosuppressive therapy by achieving remission or inactivity, low recurrence rate, and improvement in visual acuity. Especially, it is safe in pediatric population. These are my references. Thank you.
Check. This drug is already approved for FDA for all forms of uveitis.
Yes, sir.
So what is the new information you are giving in this paper?
This is
Because this is the result in all the trials also. So what is new in this paper?
we are especially studying in pediatric age groups.
But already there is one publication which says 56%
Yes, sir.
is doing well with this. So almost 60 and 56 doesn't matter. So anything new in this as such?
New in the sense we can start this earlier, sir, before starting any other, rather than trying on with the other immunosuppressive agents itself. That could give a better option.
So other than the 1 patient who developed tuberculosis, did you have to change the drug or add some other drug in any of your patients?
In between, they had recurrences, sir, when the patients were on adalimumab itself, and those patients were already steroid-free. Then in those patients, again, steroids and maybe methotrexate or MMF, one of them had to be added.
But you didn't have to withdraw adalimumab at any
No,
stage
we
and
didn't
replace
withdraw
it with...
adalimumab, sir.
Thank you. Dr. Vinita Vijayan for the next presentation.
Vinita is not.
Vinita is not there. We call upon Dr. Gemini Isaac.
Good afternoon, everyone. I'm going to present a comparative study between optic nerve sheath fenestration with thecoperitoneal shunt and ventriculoperitoneal shunt in diagnostic cases of papilledema study done in a tertiary eye care center in South Kerala. We know that the total sum of volume of brain CSF blood in the cranium remains constant, and when the balance is lost, it leads to raised ICP, and raised ICP, intracranial pressure causing papilledema, and which in turn cause significant vision loss if it is persistent. To reduce the ICP, we need surgical intervention, especially in cases of idiopathic intracranial hypertension when conventional medical therapy fails, and space occupying lesions when surgical treatment fails to relieve obstructive hydrocephalus. So always there is a confusion, the effectiveness and safety of all these procedures, because these procedures are not that common. So comparing different methods of CSF diversion procedures will help us better understanding and the effectiveness and complications, and so that we can choose in between for the better visual impairment of our patient. Aim of the study to compare different methods of CSF diversion procedures and optic nerve sheath fenestration in the treatment of papilledema. So, and also to know the efficacy and safety of each procedure. Study conducted in a tertiary eye care center in South Kerala, and the study intervention is CSF diversion. For that, we referred patients to tertiary care center where neurosurgeon is available. Our study duration was 2 years and sample size was 24. We included patients with papilledema, and for atrophic papilledema, we selected patients based upon the optic nerve sheath diameter with the ultrasound B scan, and we excluded IH cases without any documented CSF opening pressure. Optic nerve sheath fenestration done in the medial conjunctival route, and optic nerve sheath fenestration with TP shunt and VP shunt done by intracranial route by neurosurgeon. So these are the visual outcomes. We measured visual outcome based upon visual acuity and visual field. That the visual function is stabilized, improved or worsened. Stabilized visual acuity means within 2 lines of Snell lens, and the vision is if it is improved more than 2 lines, and worsening means it visual acuity reduced more than 2 lines, and visual fields if it is remain within 5 degrees of center field, that means the stabilized fields. Improved means more than 10 degrees center field, and field constriction if it is remained within 5 degree. And the papilledema resolution we evaluated with the fundus examination and the serial fundus photograph, and which is objectively evidenced by the OCT RNFL thickness, which if the OCT RNFL thickness is more than 200 microns, that means persistent edema. If partially resolved means it is remaining, RNFL thickness is remaining between 150 and 200 microns, and is totally completely resolved means if the RNFL thickness is more than less than 140 microns. So these are the results. The mean age of patients 30 years. Out of 24 patients, 8 males and 16 females. Complete resolution of papilledema seen in all cases. And these are the 3 months and 1 year follow. In the three months follow, we can see that both the optic nerve sheath fenestration cases and the decuperitoneal shunt with optic nerve sheath fenestration, these cases in visual acuity and visual fields improved. It's in a limited period, and the 1 year follow shows that all the cases, all the group, the optic nerve sheath fenestration group, shunt group, and BP shunt group and TP shunt group, which is either visual acuity and visual field stabilized or improved. This is the outcome. The visual acuity and visual field stabilized in 8 patients out of 24, improved in 13 patients, and visual acuity and fields worsened in 3%. So we compared our study with other major studies. You can see that the first 2 studies, it is only optic nerve sheath fenestration, where the visual acuity improvement is more than 90%, which is comparable to our studies. And all the other major studies, complications are more with the LP shunt compared to the VP shunt. But our studies, VP shunt is complications are more. When you see the comparison, you can see that optic nerve sheath fenestration, only subconjunctival hemorrhage was there, no other complications. And optic nerve sheath fenestration and TP shunt, intracranial hypotension noted in 1 patient, VP shunt, but there was some CSF leak, shunt malfunction, abdominal end obstruction were there, which is comparable to other studies. So coming to the discussion, these are the major causes for papilledema we saw in our study. It is majority cases idiopathic intracranial hypertension and space occupying lesions. And TP shunt and optic nerve sheath fenestration have the advantage of no intracranial complication compared to VP shunt, because VP shunt you have to operate through intracranially, the other one is outside. Visual recovery was dramatic in cases with underwent 2 procedures at a time, that is optic nerve sheath fenestration and TP shunt. And among 24 patients, visual acuity and field stabilized in 33%, improved in 54%, and worsened in 13%. These are the cause for the vision deterioration. In shunt cases, shunt failure and multiple shunt revisions, optic nerve sheath fenestration cases, late stage intervention. To summarize, CSF diversion plays a major role in the treatment of papilledema in IH when the medical therapy fails, and in case of fulminant IH, in case of intracranial space occupying lesions when the surgery fails to relieve obstructive hydrocephalus. Fast visual recovery seen in optic nerve sheath fenestration plus TPation as evidenced by the 3-month and 1-year follow-up. Optic nerve sheath fenestration is gives fast visual recovery without much complication. Early surgical intervention gives better visual outcome. Light perception vision, that is very poor vision, will not have any surgical outcome. The complications like shunt failure is more common with VP shunt than others. To conclude, all modes of CSF diversion procedures and optic nerve sheath fenestration are beneficial for the treatment of papilledema and to preserve vision. When two procedures are combined, fast visual recovery, and ONSF with TP shunt is safer compared to VP shunt. This is the first study to compare optic nerve sheath fenestration with TP shunt with optic nerve sheath fenestration and VP shunt. Thank you.
Papilledema is essentially a bilateral disease. Did you do the procedure in both eyes?
Yes,
If
sir.
so, both eyes, the same procedure.
Same procedure in optic nerve group with optic nerve sheath fenestration alone, 1 by 1 we did, and in intracranial route where the neurosurgeons operated, they did at a time because it is easier for them to access at a time.
And you have been mentioning that X number of patients improved. Did you compare between the two eyes? What was the improvement? Because if you have 24 patients, there are obviously 48 eyes.
Comparable improvement, significant vision improvement seen in both the eyes. And when we did the first eye, second eye also got a little bit improvement. But we proceeded with other eye surgery because of most of these patients present at the time of presentation, visual acuity was poor. So we need to protect it as early as possible. And majority of cases, intracranial space occupying lesion with obstructive hydrocephalus. So rapid rise in pressure is expected. So we have to intervene rapidly.
No, sir is asking different question. When are analyzing the data, the analysis should be for 24 patients, not 24 patients, it's 48 eyes. That's what sir is asking. Whether the data was analyzed for 48 eyes or 24 individuals.
24 patients, 48 eyes, sir.
That was not there
That
in
did
the
not come up in your table. What was the improvement in the right eye of patient number 1? What was the improvement of the left eye of patient number 1?
Sir, that is both eyes vision improved to 6x and 618.
Okay, then vision was not an only criteria. You said visual fields.
Yes, sir. Visual fields initially that was constricted, totally constricted field and tubular vision, which improved to more than 10 degrees central vision improvement. That is, patient is able to manage day-to-day activities very nicely.
When you are giving a talk on this topic, that is fine. But when you are presenting a study, there should be an analysis and a comparison between the two eyes, and that should be there in your analysis. When you are talking about optic nerve fenestration, this much is fine. Thank you.
Thank you.
Next we have Dr. Rikhu AC.
Good afternoon, everyone. Just presenting a case series of post-cataract surgery optic neuropathy. So, cataract surgery is the most common ophthalmic procedure, and this PCSON is a recognized entity. It is rare but serious. So, we know usual complications include corneal edema, endophthalmitis, CME, etc. And optic neuropathy is an uncommon late complication. Immediate also it can occur, for example, if there is a retrobulbar injection which inadvertently go to the optic nerve, then it can lead to. This is not that. This is here we are discussing those which happened as a delayed more than 4-month duration, and just 4 cases only, and also the outcomes between manual SCS and phaco emulsification. So 2 underwent SCS and 2 underwent phaco, and I did the surgery at a government general hospital district level hospital, and all developed optic neuropathy more than 4 months duration. So the theories include vascular theory, toxic theory, immune-mediated response, multifactorial mechanism, etc. And only very few reports exist, and they say it happens after months after uncomplicated surgery. So coming to the one first patient, 62-year-old male, had gradual painless vision loss 6 months post-op. He underwent SICS under topical anesthesia. Actually, I do topical SICS, which not purely topical, some intracameral lignocaine preservative free is also given. This saves time for me from the block, and there is nobody to give the block actually. So here this the patient, and in right eye the vision was only counting finger 2 meter. Otherwise uncomplicated surgery, PCL well centered, but there was a optic disc edema and pallor, and his visual field findings were not recordable. OCT RNF was normal. MRI brain and orbit also gave normal studies. So suspected is optic neuropathy post cataract surgery, and some oral steroids were given taper dose, but there was no improvement. Patient was not having any systemic diseases, so NAION could be a thing, but we cannot say that it is indeed the thing. And these are other differential diagnoses. So in next patient is 80-year-old female with controlled hypertension and vision decline after 5 months post-op. She also underwent SICS. This is the patient, and there is a swollen disc, and this is the MRI report. It says some chronic lacunar infarctions in bones, but not related to this, I would say. So, and orbit also normal. So the impression was optic neuropathy post cataract surgery. We referred this patient to medical college, but they actually thought it could be an NAION and didn't actually give any particular treatment. And we can see a sclerosis. This is a pictures after that, some 2 months after this, and there was total optic disc pallor and some sclerosed vessels. So patient is hypertensive, so could be an NAION also. That differential diagnosis there. And in patient, third patient, 64-year-old female, diabetic patient on oral medication, it was controlled, and the complaints included was a visual field defect at 7 months post-op. She had undergone background sedation and topical anesthesia. So, and there was a diffuse disc edema was there. Vision was 6/60 in that eye, and visual field findings. There was an altitudinal field defect was there. Don't have the picture of that, and OCT or NFL was normal. MRI also normal. So only multivitamin therapy is, again all this was done in the referred to the government medical college. They just gave just multivitamin tablets only. There was no improvement. Another patient, 66-year-old female, no systemic illness, poor central vision after 6 months follow-up. She also had background vision, and vision in left eye was 40 finger 3 meter. There was a disc edema. She couldn't take the photo, and she was lost to follow-up. And so PCSON here occurred both after SSS and FACO. There is an onset which is delayed. All cases are unilateral, where the surgery had happened, and the segment was quite. So maybe some few have systemic disease like diabetes, hypertension, so that could be the risk pattern. The surgery was uncomplicated, and we recognize the edema, so disc edema, but still we couldn't do much about it. And so implication, surgeons should be aware of an entity called PCSON, and patients need long-term follow-up, and patient counseling is important for delayed complications. So even though it is rare, but it's very significant, as it can lead to such visual loss, and the patient may ultimately blame you. And occurs in his surgery, and prognosis is guarded. This have only limited small size only, so that is a limitation. So we need a larger studies. These are references.
Thank you, Dr. Reku. Were all these cases with fundus view preoperatively, and did you evaluate the fundus?
We have evaluated. I don't have a photo, but the fundus was evaluated, and immediate post-op and after 1 month post-op, the vision was good.
Okay. That means the vision dropped after cataract surgery, not that
Yes.
it did not improve. It dropped.
No, it improved. Initially, after cataract surgery, it was improved.
It is improved and then it dropped.
Only delayed this problem happened 4 to 6 months after the surgery.
And why do you attribute it to your cataract surgery then? 4
was
to
there-
6 months following cataract surgery, the patient developed an optic neuritis. Why do you want to attribute it to your cataract surgery?
Yes, it may not be that. It's like it could be just NaON, and the studies do say that the incidence of NaON can be similar. Incidence can be there. So we are just, or some other reason for optic neuropathy, but we are just contributing the cataract surgery for that. But the recent entity for called PCSON, where it is immediate, happens very late and after delayed, and so such an it's really a confusing entity actually.
Actually, my thing is totally different. Actually, like I've gone through your abstract. I think you'll remember your abstract. Okay, so let us not elaborate, but you have to change the abstract, because given a chance, I wouldn't have accepted that abstract. Number one. Number two, in your abstract, you said 6 cases. Your abstract, which was submitted, which I read, says 6 cases. But this was trimmed to 4 cases. And I think second, third, fourth cases are maybe A-wide. In order to rule out, I think you have to see the fellow eye also. If the fellow eye is having a disc at risk, then it is obvious that it is A-wide. Had the risk factors also. 2 patients were hypertensive, right? All 3 are hypertensive.
Thank you. The last presenter of this session is Dr. Mridula Gangwar.
Good evening, everyone. My study is on biomarkers for poor response to intravitreal aflibercept injection. So, polypoidal choroidal vasculopathy and neovascular AMD remains leading cause of vision loss in the aged population. And intravitreal anti-VEGF agents have revolutionized the management of these conditions by effectively improving vision and anatomical outcome. So, aflibercept is the current preferred drug of choice for neovascular AMD and PCV due to its safety profile and various mode of actions. So, but still a significant proportion of patients exhibit suboptimal or poor anatomical and functional response to anti-VEGF therapy, posing challenges to optimal visual outcome. Data on this, especially involving aflibercept, is minimal, particularly from the Indian context. In this study, we have attempted to identify few biomarkers which likely are responsible for poor outcome with aflibercept injection in Indian eyes. So the aim of this study is to identify these OCT biomarkers in naive patient as well as in pre-treated eyes, in neovascular CNVM and cases and PCV cases, and by using multiple protocols. So it is a retrospective study which was done at Tertiary Eye Care Center in Trivandrum. Total 120 eyes were taken, out of which 30 eyes were taken as poor responders, and 18 months of data was taken for the study. Inclusion criteria were intravitreal aflibercept injection in minimum of 3 doses of loading dose, followed by a particular protocol in pre-treated and treatment naive eyes. The diagnosis was made on the basis of angiography, and OCT was taken if angiography is not done. And at least 12 months of follow-up was done after aflibercept injection, and these are the exclusion criteria. Non-responders were considered as if there is no improvement in visual acuity, or there is increase or no change in intraretinal fluid and subretinal fluid, and switch was done. Switch was to another molecule was done if both criteria were met, and these are the factors on right side which we have studied on OCT. A statistical analysis was done And the mean age group of this study was 74 years, and most common association was seen to be with diabetes mellitus, though no systemic factor was found to be statistically significant for poor responder. CNVM cases were more than PCV, and treatment naive cases were more than pre-treated eyes. The mean number of injection was 5.02. If we talk about the protocol, among poor responders, around 50% were on PRM protocol, while rest were either on 3 monthly fixed protocol or treat and extend protocol. So does the type of PED influence poor response? Yes. If we talk about fibrovascular PED, peaked PED, multilayered PED and hemorrhagic PEDs, these were associated with poor response to aflibercept. So does the type of PED predicting poor response is disease specific? Yes, it is disease specific. As you can see in this table, if we talk about subfoveal fibrovascular PED, peaked PED, multilayered PED and hemorrhagic PED, these were predominantly seen in PCV eyes when we compare with neovascular AMD. Other OCT variables that influence poor response were persistent SRF after loading dose, intraretinal hyperreflective foci, and subretinal hyperreflective membrane. So we also looked at when is SHRM and HRF particularly relevant. So we found that if SHRM is associated with fibrovascular PED and persistent SRF, that showed poor response. And in HRF group, if it is associated with multiple PEDs, that also showed poor response to aflibercept. Is there a difference between treatment naive eyes and those previously treated? Yes, definitely. Pre-treated patient showed a significantly higher rate of poor response associated with multilayered PED, persistent SRF and SHRM, and these needed more often switch therapy. So these are few examples where I am showing multilayered PED, SHRM and hemorrhagic PED before switch to another molecule. And you can see this is before switch group is after loading dose of anti-VEGF or till 6 months of aflibercept injection. And on right side you can see after switch activity was grossly improved, and it is still like this till 6 or 8 months of switch therapy. Come to the discussion. We found that PRN protocol eyes likely to have poor response, and fixed protocol did as well as treat and extend protocol, and this is in the line with pre-existing literature. Subfoveal fibrovascular PEDs, multilayered PEDs and PEDs predict poor response to aflibercept. This is also published in multiple studies, but one study where they talked about serous PED, their results were contrary to our study, and in one study related to multilayered PED where favorable response is reported in a case series. Presence of persistent SRF after loading dose correlate with poor anatomical visual outcome. This can be seen in a meta-analysis published very recently, and presence of persistent SRF, IRF, SHRM, HRF and OCT correlate with poor anatomical and visual outcome. This also supported by a 5-year real-world study and the other studies also. These are my limitations where comparison with good responder not done, and it is a retrospective study. So on this we can work further. So talking about all this, what is the take-home message? Is PRM protocol is not the best option in neovascular AMD and PCV. So fixed protocol is a good option if TA is not feasible. Fibrovascular PED, multilayered PED and peak PED predict poor response. So identifying these features early can help realistic expectations and guide closure monitoring. Presence of persistent SRF after loading dose, baseline SHRF and HRF correlated with poor anatomical and visual outcome, and these features should prompt re-evaluation of treatment strategy, and pre-treated eyes demonstrate more resistant disease. So early aggressive treatment in naive patient can improve prognosis. Thank you. Yes. Sir, most of the in pre-treated eyes, most of the patient took either ranibizumab or biosimilar. And after, if not responding, like then we changed to aflibercept. Still they were not responding, and at least after 12 months of therapy, we changed to either brolucizumab or faricimab.
And what's your follow-up? How many injections of aflibercept did you follow up with?
Sir, minimum 3 loading doses were given, and we followed up according to one protocol. If it still is not responding to aflibercept injection, then we change to the switched molecule.
Like after 3 loading dose, how frequently the aflibercept were injected in these cases, because your follow-up is for 1 year. So what is the mean number of injections in 1 year?
Sir, 5.02.
5.02.
Yes.
So when you will switch over to brolucizumab? When you switch over to brolucizumab?
So brolucizumab, we after loading dose, we see the response. If response is feasible, reasonable, then it is okay. If it is worsening, OCT features are worsening or visual improvement is not coming, then we are switching to brolucizumab or faricimab injection.
Thank you. I thank all the presenters for the excellent presentations which you made. Those who win the awards or even otherwise, take these studies forward and make sure that it comes on as hard copies and black and white. So don't just stop with this. Whichever study you can take forward, please do it. Thank you. Best.